Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers. Today, everything you wanted to know about ringworm and then some. Avrom Caplan is an assistant professor of dermatology at New York University and talks to Dr. Josh Sharfstein about this common skin infection and some not so common changes now being seen around the world. Let's listen.
Dr. Avrom Caplan, thank you so much for joining me on Public Health on Call to talk about ringworm. And I want to start with perhaps the only piece of good news we'll be talking about today, that ringworm is not actually a worm.
Thanks for having me. Really happy to be here. And that is right. It's not actually a worm. It's a pretty poorly named superficial infection of the skin, the hair, nails. And the general public is probably very familiar with this infection. Other common names for it are jock itch or athlete's foot. And there's probably a lot of people out there who have struggled with this. Older estimates are that 25% of the world's population is impacted by quote unquote ringworm at any given time. And that number may be higher in sort of high risk, high prevalence areas.
So now to the bad news, in a sense, which is that ringworm is actually a fungus. And let's just walk through what a typical ringworm fungal infection is like and how it's treated. I'm a pediatrician. I certainly remember seeing many ringworm infections and just prescribing a cream for it. But let's talk about the range of kind of typical infections.
So often what we see is a lot of athlete's foot and jock itch, where people come in and they have some scaling, itching on the feet, between the toes, the bottom of the foot. And people are probably trying things like over-the-counter antifungal creams and sprays. When it's on the body, the reason it's called ringworm is that it can show up as a round spot or plaque. By plaque, I mean it's raised a little bit, and it can be scaly and very itchy. People may have one spot or scattered. And then jock itch is what we call ringworm when it shows up in the groin area. The technical names for these people may be aware of too are tinea. So tinea corporis is on the body, tinea cruris is in the groin, and tinea pedis is on the feet. Now, this fungal infection is superficial, meaning it affects the skin, but also the hair follicle areas and then the nails. So if it happens on the scalp, that we see more commonly in children, tinea capitis, and people may be familiar with that in their children. That's typically treated with oral medicines. And then it can happen in the fingernails too. And for anyone out there who may struggle with this, they know it can be hard to treat when it gets into the nails. And we typically see that in an older population. And that's called onychomycosis. And so people may have heard some of these technical terms as well.
Walk me through the various typical treatment options.
Sure. It depends a lot on where it happens on the body. So the typical treatment for scalp and hair follicle areas is going to be different for the nails because that fungus is more locked into the hair follicle and the nail. So we need to use oral therapies typically for those areas. When it happens on the body, the typical treatment is creams. So topical antifungal creams, people may be familiar with these, clotrimazole or terbinafine cream. I'm going to avoid using some of the brand names, but these are widely available over the counter in pharmacies. And it can take 2 weeks, it can take 4 weeks. People know that this can come back. So if you treat athlete's foot or tinea pedis, you might need to treat for a few weeks and then it might come back. Sometimes I have people treat their shoes. I talk to people about not wearing shoes without socks because then that fungus can kind of get into the shoe and all of a sudden you just spent 4 weeks putting creams on your feet and you put your foot right back into a shoe that has fungus spores in there. Those are the typical ways I approach it when I see it in clinic.
Now, in the last few years, dermatologists have been seeing more severe ringworm infections, and that's really why we're talking today. Tell me about what is breaking through this routine, superficial skin infection.
Yeah. So the last few years, there's been a large number of reports coming out, in particular of South Asia. And we've learned a lot about this infection from dermatologists and scientists around the world. And it's still superficial fungal infection, but it's become much harder to treat. And it seems to spread more easily between people. Now, this is a type of fungal infection that was sequenced in a scientific study in India a few years back and given a new name, and has been now reported worldwide. What's different about this infection is that it can be more widespread on the body. It can be very, very itchy. And unlike other strains of this fungal infection, it can be harder to treat. So topical creams don't seem to work very well. People really need to go on oral medicines and take them for a long time, 8 weeks, 12 weeks, or even longer. Now, we had reported with the CDC the first 2 confirmed cases in New York back in May this year. And I stress confirmed because in hindsight and with additional studies, we know it's probably been around in the US a little bit longer than that. But we're not seeing the kind of spread that's being reported in other countries. And typically, what we're seeing in our clinic is acquisition abroad. And so I think that's important to remember too. But unlike other patients who are coming in with more of what we just discussed as localized ringworm or tinea, this tends to be more widespread, more atypical in how it looks, maybe more inflamed, more itching. And that's what we're seeing now.
Is it hard for physicians to diagnose because it looks so different from the typical ringworm?
It can be. It can be more challenging to diagnose for a couple of reasons. It can look atypical, and that can throw people off. The amount of itching that people are having with this can also throw people off, even though ringworm typically is very itchy. And then sometimes what we're seeing is that patients are using topical anti-inflammatory creams because they are so itchy, and that helps with the itching. But the problem is it can make the tinea infection worse, and it can sort of mask what we look for in the typical appearance of tinea. So someone will come in using a topical steroid cream, and it makes it harder to diagnose and a little harder to confirm.
Right. The steroid reduces the inflammation a little bit, maybe makes it a bit less itchy, but actually also suppresses the local immune response and can make the infection worse.
That's right.
Now, how do people get this atypical form of tinea? And I think maybe I should have asked this question more generally because fungus is in the environment. You can get it perhaps from someone else who has an infection like this. But in general, how are these infections spread? And then in particular, these atypical infections?
Yeah, it's a great question. There probably is some predisposition to getting tinea infections. It is in the environment, and we know a lot of people have it. And typically what they have is the kind of localized infection we've just been talking about. There's sort of a twofold way to approach that question about how people are getting the newer reported, more atypical one is, where did it come from originally? And then how is it spread now? And how it's spread now is people think it's spread between people. One of the questions that comes up when dealing with tinea infections is the possibility that it's coming from an animal. So we know there's some forms of tinea that people can acquire from pets. This particular new strain, while there is some discussion in the literature about potential animal source or spread, that's really not widely reported. And typically what is written about is the potential for spread between people.
You mentioned that when these more severe infections happen, there's no role for topical treatment alone because you have to use the oral therapy. Are all the oral therapies working?
No, and that's another feature of this infection. But I think that's a great question for a couple of reasons. One is because you said don't use topicals alone. And I still use topical therapies as part of this treatment approach. But you're right, I don't use them alone. One of the features of this newly identified strain of tinea is that it is typically resistant to the first line oral therapy that we've used for a long time. Not always resistant. It's not an intrinsic part of this infection, but typically it is resistant to the first line therapy. We have other therapies that we use. The current therapy of choice is one that we're not typically using for tinea infections. We were using it for more systemic fungal infections. And then we weren't using it for as long when we did need it for tinea infections. Now we're using it for, 2 months or longer to treat this infection.
So someone gets a typical infection, either from person to person, spread rarely in this country, but potentially from experiences in other countries where it's more common. they come here, they may have trouble getting diagnosed. Finally, you figure it out, and you're in for potentially a couple months of oral therapy, and then crossing your fingers that it doesn't come back.
That's right. Yeah. And there are reports of relapse even after 8 weeks of oral therapy with one of our stronger antifungal medicines.
Dr. Caplan, is there anything else we need to know about new strains of fungus that are causing skin infections?
Yeah. In particular for the tinea infections, it hasn't yet been reported in the US, but there is a recent report out of France of tinea infections being sexually transmitted, in particular in this report among men who have sex with men. It's not the same as Indotineae, which is the strain we've just been discussing, but very similar, very related. And what they found is that it was showing up on the body in areas of sexual contact. And so that's something that the general public and we as clinicians need to be aware of too, because that's something different. Even though we do think about tinea infections being spread by skin-on-skin contact, what they're describing is a particular form of spread that seems to be primarily sexually transmitted.
What is this emergence of a new, more severe ringworm kind of tell us about the world we live in? I say that because ringworm, I always thought of as maybe one of the easier diagnoses to treat. And now all of a sudden it becomes something to worry about. What do you think that means?
Yeah, I think it means the world is just very interconnected. And I think that's a big part of the world we live in now. And we've seen that multiple times throughout the last few years, is how small the world is and how easy it is to get around and travel and visit. And that's a wonderful thing. It brings us all closer together and we can experience cultures and travel and see the world and meet people in a much more interconnected way, which I think is wonderful. But it also means that some of the aspects of being human, like having diseases or, the ability to acquire infections, is also spreading. And so I think that's one thing that this tells us. I think the other thing is it tells us that we have to be good stewards of antifungal medicines, the way we're good stewards of antibiotics. We need to really focus on getting the correct diagnosis of a fungal infection, using medicines appropriately, topicals and oral antifungals. And we need to think about how we're going to approach this new type of fungal infection at multiple levels, the clinician level, research, state, local, national public health authorities all working together to tackle this.
Dr. Avrom Caplan, thank you so much for coming to talk to us about a fungus, not a worm, but a fungus that we have to pay attention to.
Thanks for having me. Really enjoyed being a part of this.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.